So thanks everyone for joining and for coming to the Women's Health Cluster Trainee Research presentations. We've got 5 awesome speakers for you today, all women's health trainees. So before we jump right into those, just a little bit of housekeeping and a few notes. So before we begin, I'll start with a land acknowledgement. We recognize that we live, work, play, and participate in community on the unceded, ceded, and traditional territories of 203 First Nations, along with 38 Métis charter communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission and of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all our work, we are committed to ensuring Indigenous women's rights to health and safety and equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you from Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, Stolo, and Tsleil-Waututh First Nations. So very briefly, who are we? So the Women's Health Cluster, we have over 420 members, which include UBC faculty, trainees, community members across 18 countries now. We host a variety of events, including trainee research presentation series, which you're at today. We have the Women's Health Seminar Series, research days, community events. In 2022, we hosted a Women's Health Brain Conference, in addition to many more events. So lots going on. So always you can check out the events calendar on the Women's Health Cluster website. Our members work in diverse fields, including medicine, economics, social sciences, humanities, nursing, anthropology, gender studies, land food systems, psychology, and education. So we are a very diverse cluster. We're very lucky to have such a multidisciplinary group. In terms of knowledge translation, we also host a Women's Health Interrupted podcast, which I'd encourage you to check out. And we also have the Women's Health blog, which features a variety of different topics from trainees to professors writing about their work. So also if you're interested in writing, you can reach out to the blog team. Their contact information is also on the website. Each year we offer some trainee travel awards. We're so lucky to have many wonderful collaborations. And of course, we can't do this work without our sponsors, which include UBC, CIHR, and BioTalent. And as always, we encourage, if you're interested in donation, these donations facilitate and catalyze women's health research worldwide. And if you're on this call and not yet a member, it is free to join. So check out that website down at the right-hand bottom screen, and please do apply to become a member. So without further ado, we'll get going here. And I'll just let everyone know as well that this session is being recorded. And the format is 5 minutes for each of the presenters and then 3 minutes for questions. You're welcome to go ahead and unmute yourself to ask your question, or you can also type it in the chat and I can read it out for you. So just to make sure everyone's aware that this is recorded, and then we do post these on our YouTube. So if you are wanting to ask a question and you want it to be cut out, you can reach out to our team as well, and we can cut that out if you're not comfortable with having that out in public. And lastly, I'll encourage people to tweet, and you can tag us in hashtag with the Trainee Blitz hashtag. And without too much further ado, we will get started here. So I'll introduce our first speaker, who is Sabine Halabi. So Sabine is a Master's of Science student in the Women's and Children's Health Sciences program in the Department of Obstetrics and Gynecology at the University of British Columbia. As a graduate researcher in the Telhouk Lab, Sabine is working on validating epidemiological risk models for endometrial cancer to inform on targeted prevention for at-risk individuals in a Canadian population. Sabine's goal is to provide a simple tool that can be used to screen the entire general asymptomatic population in order to target those at risk for endometrial cancer to appropriate screening. The hope is to greatly reduce screening burden while also reducing rising incidence and mortality rates for endometrial cancer. And Sabine was awarded the Canada Graduate Scholarship for 2022-2023 for her continued work as a graduate researcher. So Sabine, I'll invite you to share your screen and you can take it away.
Thank you, Alex. I'll just share my screen real quick. Can everyone see my slide?
Yeah, looks great.
Okay, awesome. Thank you. Okay. Good afternoon, everyone. My name is Sabine, and I'm a student with Dr. Aline Telhouk, and today I'll be discussing a part of my work with risk models, which is integrating gender and socioeconomic status indices as predictors into the endometrial cancer risk models. So endometrial cancer is the most common gynecological malignancy in the developed world, and it usually occurs when there are hormone imbalances that cause the endometrium to proliferate uncontrollably. And unlike other cancers that have seen improvements in recent decades, endometrial cancer incidence is rapidly rising. And what's really alarming is that although it's more common in older postmenopausal women, we're seeing an increase in younger women as well. And these increased incidence rates are also accompanied with these great disparities. For example, people with different socioeconomic statuses. And so current screening methods are effective, like biopsies, but they're not feasible to provide to everybody in the general population to screen them. And they also don't address disparities because they cannot. And so one promising solution that we're working on is risk models. And so what risk models do is they take a bunch of predictors or exposures that someone may be exposed to, like their anthropometric variables, demographic variables, and so on. And we assess their weighted effects on an outcome. And then using that person's exposures, we create some sort of sum score that basically represents their risk of a cancer or any outcome over a specific period of time. And so what we want to do is include predictors or variables in these models that address disparities so we can improve generalizability of the models to all populations. And we're interested in two factors that aren't well researched in endometrial cancer specifically, and it's gender roles and socioeconomic status. And gender roles refers to the social behaviors that a person lives that may expose them to different variables that affect health outcomes. And socioeconomic status variables are already well established to affect health outcomes in society. And so each of these variables have a lot of different variables that are associated with them, like income, education, and so on and so forth. And the list just is so long. And we want to include all these variables to make the model very well predictive. But we can't because it's not statistically efficient to include a million variables in a model. And so what we're deciding to do is to create indices where it takes all the variables associated, for instance, with socioeconomic status, and it averages out their weight to create one composite single score that represents that one umbrella variable. And then we can include that one variable as a predictor in the models more efficiently. And so our objective is to create these indices in the Canadian Partnership for Tomorrow's Health dataset that we have, which contains biological, environmental, social variables for over 100,000 Canadians. And we want to integrate them as predictors into pre-existing risk models that we are reproducing. So there's about 2, but none of them have been validated in a Canadian population. And so after a lot of research, we found a couple indices that have similar variables to what we have in our data set with outcomes that are specific to them, different chronic diseases, but they gave us variables that are related to gender and gender roles and socioeconomic status. And they used specific stats methods, which is another 10-minute presentation, to assess their weights based on their outcomes. So what we did was we took the weights that they had for their variables and we applied them to our variables and created these index scores for each participant in the CanPath data set that we have. And after reproducing those index scores for each individual, we wanted to assess the indices as predictors and their association with endometrial cancer risk scores that we produced from the risk models that we were reproducing, and just to see if they're statistically significant. And if they are, then we can move forward with integrating them into our risk models as predictors. And so thus far, we've been able to reproduce the indices and produce scores for each individual in CanPath. And we now we did a very quick preliminary stats assessment for each index independently and together to see if they're statistically significant in association with the risk scores from one of our models. And we saw that they are both independently and together statistically significant. And so we're going to move forward with obviously more statistical assessments and then integration into our risk models to see if they are really good predictors, basically. And our next steps are to integrate them through methods that we're still looking into because it's kind of a newer thing that's happening in risk score studies. And including them as predictors, we're hoping to improve generalizability, which means we're able to apply the models to all populations without discriminating against any one. And their ability to actually target those at highest risk and target them to appropriate screening will greatly reduce the burden of and the use of resources. So thank you to everybody and my research team that is working on this. And that was just a very fast explanation of just part of the work that we're doing in risk modeling.
Thank you so much. That was great. Really interesting work.
Thank you.
Any questions? And again, you can just unmute yourself or type it in the chat. I have a quick question. I always do, but
yeah.
Do you have any sense of how this could be integrated into practice? Like say down the road, you find that you are able to create a prediction model that is, you know, valid, reliable, all that stuff.
Yeah. Yeah. So actually something really cool is we're actually prospectively validating it already in a trial in our lab. And so we're kind of seeing it in practice before it's actually deployed. But basically what we're doing is there's a study in our lab that's trying to reduce the burden of like having to give everybody a biopsy, similar to like what my study would be helping. So they're taking my risk model and they're testing everybody in their population of like participants coming in, and only those at high risk will get a biopsy and others will only get like lifestyle interventions instead of having to give everybody that they think is at risk for cancer a biopsy. And so that's kind of like a practice, like something in practice that's happening with the risk models. And we're just like seeing if it works, and hopefully it does. And then hopefully gynecologists and physicians in general will be able to use this as a really quick tool, honestly, because it's fast. It's just a bunch of questions of data that they already have at hospitals. So it'd be really cool.
Very exciting.
Yeah.
Just asked, could you give some examples of gender roles that would make someone more likely to be predisposed to endometrial cancer?
Yeah, so gender roles, we wanted to stress that it's not about gender identity. And what we mean by gender roles is obviously there's already a lot of studies on sex differences in health outcomes, but what people don't realize is like, say I'm a female assigned sex at birth, but my lifestyle could be more traditionally male, where traditionally male lifestyle would be working in a male dominated job, less responsibilities at home. And this is all based on like traditional literature. And so what we want to show is, first of all, females assigned sex at birth who are affected by endometrial cancer can be on that spectrum of either a more female lifestyle or male lifestyle, but that maybe high stress lifestyle that doesn't make them female gender roles can put them more at risk for any disease, really. So those are just an example. And like those are, a variable is stress. We don't really have that variable, but like that's just an example. But yeah.
Great. All right. I mean, there's always so many questions, but we'll move on. And then obviously I think as well, if anyone has questions afterwards, can reach out to the speakers directly or reach out to us and we can share information as well. So next up, we'll have Charisse get ready to present. So Charisse Kwok is an undergraduate student at the University of British Columbia, who's currently majoring in behavioral neuroscience. Broadly, her research interests are focused on exploring how psychosocial factors impact physical and mental health outcomes and the sex differences in behavioral and neural consequences of stress. So go ahead, Charisse.
All right, so hi everyone, my name is Charisse, and I'm part of the Laboratory of Behavioral Neuroendocrinology, and today I'll be presenting on sex differences and the effects of chronic unpredictable stress on negative cognitive bias and neural activity in the amygdala and nucleus accumbens. All right, so to start us off, major depressive disorder is the leading global cause of disability, yet few studies have explored sex differences in the neurobiology of MDD, despite females being more susceptible to severe symptoms and at greater risk of developing MDD compared to males. And negative cognitive bias is a key symptom of MDD, influencing its onset, severity, and maintenance throughout the lifespan, with females demonstrating a higher prevalence than males. Notably, negative cognitive bias is linked to treatment resistance and a prediction of MDD onset, highlighting that it really needs for additional research on the cognitive symptoms of MDD, particularly with regards to sex differences. Now, the previous slide has established a connection between negative cognitive bias and disrupted activity in the amygdala and nucleus accumbens regions among individuals with MDD. The nucleus accumbens in particular has been linked to cognitive bias modification, while the amygdala is activated during negative thinking and cognitive bias. However, there is a gap in research examining sex differences in response to negative cognitive bias within these brain regions in humans. So in our lab, we did a lifespan rodent study, which found increased activity in the nucleus accumbens and amygdala in non-depressed females compared to males. So this study wanted to further investigate these findings by using chronic unpredictable stress paradigm to induce MDD-like symptoms and examine negative cognitive bias and the neurobiology of the amygdala and nucleus accumbens. And to our knowledge, this is the first study to investigate these factors in response to chronic unpredictable stress. So this came to our hypothesis that these regions would be involved in negative cognitive bias, and the role differs based on sex and chronic unpredictable stress. So moving on to our procedure, prior to cognitive bias assessment, male and female rats in the experimental group were exposed to chronic unpredictable stress. They were given 2 stressors per day, which is shown on the slide. And while the control group was not, then they moved on. The experimental group then underwent a 14-day chronic unpredictable stress procedure with 2 daily stressors, and both groups then underwent a 16-day cognitive bias training where context A rats received shocks and context B did not. And the rats alternated between these 2 contexts for the whole training period. Then on the test day, rats were placed in an ambiguous context and subjugated to shocks or not, and freezing served as an indicator of cognitive bias. And then the following day, their brains were harvested and stained for CFOS, which is an immediate early gene, which allows for the visualization and also the count of active neurons during test day. So now moving to our results, from freezing alone, we found that rats that underwent chronic unpredictable stress froze significantly more than no stress rats, which indicated that COS increased the prevalence of negative cognitive bias. Now, when examining neural activity, we looked at the nucleus accumbens core and also the shell. We found that male rats that underwent COS or no stress did not show any significant differences. However, in female rats, there were significantly higher activity observed in the nucleus accumbens compared to males, which indicates greater activity in females regardless of stress exposure. Then moving on to the amygdala, which we examined the basolateral amygdala, central, and also lateral amygdala. Female rats that underwent chronic unpredictable stress or no stress showed similar levels of neural activity, whereas in male rats that underwent chronic unpredictable stress showed significantly higher neural activity than no stress rats. So overall, it can be said that chronically stressed male rats exhibited significantly more amygdala activity than their non-stressed counterparts. And this comes to our conclusion. So the findings suggest that sex-specific roles of amygdala and nucleus accumbens in negative cognitive bias following chronic unpredictable stress in rats. And this can inform the development of tailored therapeutics for MDD and also investigate altered connectivity between brain regions, which can provide targets for sex-specific interventions for depressive symptoms. And then for further directions, we can definitely expand on the scope of brain regions under investigation, which can offer a deeper insight into the impact of chronic unpredictable stress on cognitive bias and neural activity. And also we can look into manipulating the activity of these brain regions to determine their influence on cognitive bias, which can help identify potential therapeutic targets for modulating the negative cognitive bias associated with MDD. And that's it. Thank you everyone for listening. And also thank you to my research team for collaborating with me on this study.
Thanks, Charisse. That is really interesting work. Any questions?
Hi, Travis.
Hello.
It's good to see you.
It's great to see you and great presentation. And yes, let me definitely ask you a question while I am here and I have caught you since I haven't talked to you in a while. So a question for you based on your data, now seeing that the females are having just this generally higher activation of nucleus accumbens, and then the stressed males are having this activation of the amygdala. So that stressed increased activation of the amygdala might be tied to more negative bias in those males. Any ideas then why the stressed females might be more negatively biased? Could there be another brain region that's involved? Could there be some other reasoning for that increased negative bias?
Yes, absolutely. So in terms of the other brain regions involved, so the neurobiology of negative cognitive bias is associated with structural and functional changes, not just in the amygdala and nucleus accumbens, but also in the frontal cortex and also the hippocampus. So definitely more research can be done in those areas to see if it modulates the negative cognitive bias that they experience. In terms of the differences, it can be also due to the length of the chronic unpredictable stress. So specifically, let me think about it. So in terms of the reason why there might be a difference, I think people can also use chemogenetics to kind of look into why and modulate the activities to see if it makes any difference between males and also females. And yeah, I would say that's like my main response to your question for the time being. Yes.
Yes, thank you. There's much more to find out in the future.
Sure.
I have some students in here that are listening, and I also want to ask you too, do you think that maybe from any of your knowledge, maybe hormones might be playing a role in any of these differences that you're seeing?
In terms of hormones, so in this study, I don't believe we looked at the, I think the estrous cycle definitely could potentially play a role in affecting negative cognitive bias. And I think in future studies, looking at that specifically more in depth alongside with the data that we currently have could definitely help explain potentially why we might be seeing this difference in neurobiology. But that is something we can look into in the future. Yeah.
Awesome, thank you. And good to see you.
Yeah. Yes, good to see you too.
Thank you so much. We'll move on, but yeah, like I said, please reach out to Charisse if you have any follow-up questions. So next we're going to have Arnima Singh. So Arnima, if you want to get ready to share your screen there. So Arnima is a third-year student at the University of British Columbia in the Faculty of Science. She's pursuing a combined major in science. Her research interests include neuroimmunology, mental health, and intervention measures. She hopes to pursue graduate studies in clinical psychology. During her free time, she can be found at aesthetic cafes studying, a pretext for justifying an unhealthy amount of coffee. I also love drinking a lot of coffee at aesthetic cafes, so I'm looking forward to hearing what you have to say. So go ahead and you can share your screen.
Thanks, Alex. Just can everyone see? Should be okay. I can minimize this. That might be a little bit cleaner. Sorry, I woke up with a bit of a cough this morning, so bear with me. But hi everyone, my name is Arnima. I'll be presenting about the EPAC clinic, the Early Pregnancy Assessment Clinic at BC Women's Hospital. I'm going to do things a little bit out of order, start with some of the acknowledgements, just because our team has changed over the years. So I do want to highlight our old PI, Astrid, and then some of our old team members, Nicole and Ronnie, who are no longer with us, but played a very big role when I first joined the team, and our current PI, Corolla, and our current research assistant, Stephen, who I'm in contact with on a daily basis. So in Canada, it's estimated that up to 25% of women will experience a miscarriage in their lifetime. And BC Women's Hospital and Healthcare is actually very unique in the care that it provides because we help women in the first trimester of their pregnancy with conditions such as bleeding, cramping, and miscarriage. The services are accessible through self-referral or by a provider when you're coming into the EPAC clinic. And then we'll kind of go through based on the symptoms and the services, and we'll decide if you're eligible for the clinic, and we'll either transfer you to the right kind of care, the right facility, and work from there. So the main kind of goal of the study was to characterize the patient population within EPAC at BC Women's Hospital and Healthcare. And the goal of this is to kind of assist with future research that's happening on women in the first trimester of pregnancy, because there is very limited literature on this topic. And also we kind of want to promote quality improvement of just the care that we provide at the clinic for a wide variety of women coming in, regardless of their background. We really want to make sure that we have a well-rounded care system that we're providing for all these women. And so we decided to run a 3-month recruitment study just to see if our current recruitment methods resulted in a biased patient sample. And that's kind of what I was in charge of, running that over the summer. So we have 2 forms of recruitment right now. The first is through passive. We kind of have posters that are posted physically throughout the clinic. And then we have information that's posted about the study on the EPAC website. The other kind of recruitment that we have is active recruitment, and this occurs during the first phone call. After some of the clinical questions we run and have a few screening questions, and an EPAC nurse will complete a recruitment data collection form that comes back to our team. And this form collects information on participants who will agree, decline, or just aren't asked for a wide variety of reasons. It'll include a brief overview of some of the information that we require, and then their preferred method of contact, which is kind of what we use for the next step. And then in the follow-up process, we will contact those who accepted and agreed, and we'll have an RA, one of our RAs, follow up. And if no contact is made after 3 attempts, the RA will no longer contact them, and we'll kind of have them categorized as lost to follow up. So some of our preliminary results from around 1.5 months is, as you can see, we have quite a few individuals that agreed, not that many that consented from the agreed, but we had quite a few that weren't asked. And I do want to highlight 2 categories here. The first is emotional state. So we have quite a few women coming into our clinic that have just experienced a miscarriage. As you can imagine, in terms of a research standpoint, it's not really a priority at that point to be asking them to participate in our research. So we do lose quite a few women in that process as well. And then the second process that we lose quite a few individuals with is the language barrier. So at this point, especially for the EPAC clinic, we don't have the resources to be able to run informed consent processes in a wide variety of languages. So to ensure that we're doing the informed consent process ethically, we just opted out for individuals that experience a language barrier. So as you can imagine, that's quite a few individuals that we're losing right there. For the other section, there's not really much that we decided we could do about it. We just ended up with quite a few individuals that weren't meeting the criteria for EPAC. As I mentioned, they come into the clinic and then we decide if they'll be able to, or if they're eligible for the treatment or care services that we provide. Then we have quite a few individuals that just don't end up coming in for their appointment. So some of the things we found and the importance of it. The importance of it is that we have an ongoing database now that we can use for research opportunities specific to women that are in the first trimester of their pregnancy. As I mentioned, this kind of helps us form a self-improvement loop. And also the recruitment process that we had the goal was to kind of reflect and look at it from kind of a holistic perspective and see if we're really gaining a sense of or getting a diverse population of women that are coming into our clinic, and we're really being representative in the care that we provide. So following the completion of the recruitment trial, we looked at kind of the data, and we decided to determine if participants are representative of our patient population or not. If not, ideally, we'll petition to recruit participants with a waiver of consent. So as you can imagine, this isn't totally done yet, but some of the results I think I can share with you. that I found is that we have a lot of women of color that are very hesitant to provide their previous pregnancy history. We have a lot of women coming in from rural areas that are a lot less hesitant, that are more hesitant, sorry. Women with certain education levels are more hesitant. And so as you can imagine, especially with just the women of color, we're losing a wide range, a wide diverse population that otherwise leads us to have a very biased kind of knowledge within our database that we then will apply to women that aren't necessarily within those categories. So for us, the goal is to really be able to be more, I would say, inclusive with the care that we're providing, especially at EPAC. Yeah, that's a very brief summary. We're still working on our research, and I think I will open the floor to questions now.
Thanks. That's really interesting work. Recruitment is really tough to do well and really tough to get right for sure. So good work. Any questions? And again, you can type them in the chat. I can read them out if you prefer.
I have a question. I'm wondering if you have an agreement with your clinic to implement this once the research is done.
So at this time, actually, I volunteer for the clinic. I no longer work with them just because of some other positions that I'm a part of, but it's something I've been a part of since first year, so I'm finding it very difficult to let go of it. But in terms of the actual application, the goal is to be able to apply this within the clinic. Some of our RAs and PIs can speak to that more, but we really do want this to be an integral part of the feedback system and feedback loop, because I think especially at the stage that the women are coming in, this is a really integral part of their pregnancy journey, and also not just them, but also the family and the support system that they have that they bring with them. And we really do want their opinions to help out with anyone else coming in. Yeah.
Cool. And I'm wondering if you guys have given any consideration into the knowledge translation plan once the project is done, so that you can share that with other clinics that are similar to the one that you're working with.
We definitely have. So we've started on some of the knowledge translation. That's kind of some of what our volunteers and RAs do. We have quite a few individuals that are interested in more of the knowledge translation and social media aspect of it, just to help with some of the stigma that I think can come across when you hear words such as miscarriage or things like that. And so we really do want everyone to feel comfortable about the topics that we're discussing. And also we want it to be a little less kind of ominous. It's just a random group of people coming in asking you about your pregnancy history. And so that we do have some of the newer RAs and volunteers. So when I first joined the team in first year, we actually had no volunteers, and now we have about 15 to 20. So we are still growing in size, and we definitely are working towards that, just as you mentioned.
Cool. Thank you.
Can I ask, do you have any idea of what sort of research you might envision coming out of this? Like, once these people have consented to be part of this, is it just more quality improvement? And if you don't know, that's okay too. I'm just curious.
From my perspective, there definitely is that quality improvement aspect. But for me, what I'm really interested in is looking at the difference between women of color and kind of their journey in pregnancy and their knowledge, especially around the stigma of mental health and miscarriage and things like that. And so that's kind of my own personal goal coming into this. And that's why I was really excited to be a part of this team, just because there was a really big push to be able to see that difference. I can imagine some of the other things that might come out of it is looking at education level, rural versus urban care, and just also looking at some of the ways that if you have a support system, how does that impact you? But I think right now the goal is to really just collect that information and decide later how we're going to be able to organize it.
The sort of consent to be contacted for potential future studies. That's what the consent is.
Yeah, and then also just being able to allow us to use your data, be a part of this. Yeah.
Right. Very cool. Great. Okay, well, thank you so much. And I think we'll move on to our next presentation.
You're muted, Alex.
Thanks. Sorry. Happens. It still happens, you know, even this far in. Okay, so we'll move on to Katherine. So Katherine, if you can get ready to share your screen. So Katherine Gray is a fourth-year medical student at UBC. Throughout her medical training, she's had the opportunity to work with a diverse group of women, including patients and mentors. This experience ignited her passion for global maternal health, especially in underserved areas. During her research in Rwanda, she was shocked by the high incidence of advanced cervical cancer and the low rates of screening, which inspired her to focus on work improving access to preventative care for women in low resource settings. She's excited to start residency in July and is currently in the process of applying to obstetrics and gynecology programs, where she hopes to continue working towards better maternal health outcomes for women worldwide. All right, go ahead, Katherine.
Yeah, thanks so much. So I will briefly share a little bit of work that I've done with the Aspire Rwanda team on the topic of cervical cancer screening. So just a little bit of background on cervical cancer. So cervical cancer is one of the rare cancers that actually is preventable with proper screening and vaccination, and yet it remains the leading cause of cancer death among women in sub-Saharan Africa. In Rwanda, there's actually very little known about cervical cancer screening, and there hasn't been any work that's explored the perspective of local healthcare providers on this topic. So our study aimed to engage with healthcare providers to explore their perceptions of cervical cancer screening, what they thought about their access to resources, their attitudes on self-collection, and integrated screening on the topic of cervical cancer in Rwanda. So what we did, we developed an interview guide based on a range of topics that I'll touch on in the next slide. And we conducted semi-structured interviews with healthcare providers from a variety of different backgrounds. And we did this study in November of 2022 at one of the largest tertiary referral hospitals in the country, along with a rural hospital on the outskirts of Kigali, the capital of the country. And yes, that is a real gorilla from Rwanda. So this is kind of some of the things that we would ask about in our interviews. So we wanted to get a really broad scoped interview sense of what that would allow the healthcare provider to talk about their experience and their background in the topic of cervical cancer and cervical cancer screening, and understand what they viewed to be the barriers that would prevent women from accessing these screening services in the country. So I'll just let you read that. So I don't have time to go over all of our results, but I'll try and highlight some of what I think are the most interesting ones. So overall, we conducted 14 interviews that included 4 OBGYNs, 5 OBGYN residents, 4 midwives, and 1 general practitioner. Some really big highlights were about lack of training. So 14 out of 14 of our participants said that they felt like they were not adequately trained when they finished from their primary professional degree program, but received some sort of additional training to do this after they graduated. And then some of the other most interesting findings were about barriers. So what did healthcare providers say about the things that they saw in their daily practice that prevented women from accessing screening? So some perceived barriers that these healthcare providers talked about, the 2 biggest themes were about transportation and about lack of patient knowledge. And I'm sure that those topics don't come as a surprise to any of us when we hear them. So for transportation, this was primarily about transportation cost. So transportation method wasn't an issue in the country. People said that they could find a method of transportation, but it was about the cost, and that was prohibitive. And secondary to that transportation cost was geographic distance. So with a majority of the country living in rural and remote regions, it's challenging for them to present to screening at some of the tertiary referral hospitals without kind of outreach programs that are going to these more rural regions of the country. And then second was patient knowledge, and healthcare providers felt so strongly about this that they found that their patients just didn't know enough about cervical cancer. This is a lack of awareness about cervical cancer as a disease entity, as well as about screening. So if you don't know about cervical cancer, you can't present for cervical cancer screening. This kind of related to a common theme being about a cultural belief that women would only seek care if they were physically ill and symptomatic. So it's about kind of allowing education to dismantle these beliefs that screening isn't necessary because they aren't symptomatic at that time, and understanding and providing education about what the benefits would be for screening to prevent a cancer down the road. Another area that we're as a group really interested in is this topic of self-collection. So one mechanism of cervical cancer screening is an HPV DNA test. So that is just measuring the DNA of one of the viruses that is known to cause cervical cancer. So what this self-collection tube does is it's an HPV DNA test, but it's just inserted into the vagina. You don't even have to go into the cervix like you would do in a pap smear, and the woman can collect these samples on their own. So this is a really interesting area of improvement that would make things potentially more culturally acceptable. And healthcare providers in Rwanda were really excited about this. There were some challenges that they brought up about wanting to overcome, but they thought this would be really an overwhelmingly more culturally acceptable way of promoting screening. And they wanted to see more about this moving forward. So this could increase numbers of self-collection rates. Interestingly, a lot of providers also knew the data about that is out there about saying that self-collection of HPV DNA tests is actually not inferior to provider testing. So we have this data that providers are aware of it, and they're ready to be implementing this. So this is just a really interesting area of future work. So overall, understanding healthcare providers' perceptions and attitudes is really a crucial step in identifying areas for improvement and developing strategies for cervical cancer screening in Rwanda. So our study aimed to fill this gap in knowledge and inform strategies for effective intervention moving forward. And that's it. Thanks so much.
Thanks. Super interesting work. Any questions, anybody? Type them or unmute yourself.
Hi, Katherine. I'm wondering if you can sort of bring us through like the next steps once your project is over. It sounds like you've got a very clear path forward about what intervention can be implemented. Can you tell us a bit about how you're planning, if you are to implement it?
Yeah, no, great question. And when we have these, like we've identified barriers of transportation and lack of patient awareness, and those are massive. And those are, you know, political and public health and governmental. So I would love to say that we could just tackle those barriers with the next step, but unfortunately that's not where we're at. I think that the next step for our group is really about that self-collection piece and seeing if there's a mechanism of being able to conduct a trial that is specific to Rwanda, about making sure that we're able to implement this on a larger scale, understanding what this would look like down the road, and making sure that this is a longitudinal intervention that patients are okay with, that providers are okay with. So that's some of the steps that we started to take in terms of assessing the country's willingness to involve self-collection. For example, we don't have self-collection really as an option in Canada for cervical cancer screening. So this is really kind of a novel method that I think would be really beneficial in that country. So that's where I think we want to go next.
Very cool. And maybe you don't know the answer to this question, but I'm just curious, do you have any particular funder in mind for that sort of implementation clinical assessment?
No, we don't. If you have any suggestions, I'm all ears. No, we don't. So obviously this was a small study, and talking about like a larger RCT about self-collection would require a much larger donor. So no, nothing identified yet, but
I'd look at the Bill and Melinda Gates Foundation. Just check and see.
Okay.
If they have
Great.
anything that fits.
Yeah, no, great suggestion. Thanks for that.
Cool. Thanks for your work.
Yeah, so there's a question in the chat. How are these self-collected samples stored? Is there any specific methods needed? Yeah, great question. And oftentimes the small amounts of self-collection that does happen in the country right now is through donor-funded initiatives, and they're quite small. So it would happen in a clinic for a period of a month or something like that. And then they run out of materials and reagents and stuff like that. So that is certainly a barrier. And then when you're talking about samples only being run in a couple of the larger hospitals in the country, then getting into barriers about transport and things like that is certainly factors. So it's not about just getting a swab. It's about making sure that we have the reagent and the people to run the tests and the vans to drive the test from a rural region to the capital and stuff like that. So yeah, I don't know that I have the specific answers to those questions, but there's certainly important logistical questions to answer before we can start talking about scaling up those things.
Great. It's really interesting. I mean, I don't work in this at all, but I know a few people that work around cervical screening in BC and cancer. It just seems like self-screening is has a lot of opportunities to improve coverage for people, especially underserved groups. So really interesting work.
Totally. Yeah, I agree.
Cool. Okay, sounds good. Yeah, just keeping on time here. We'll move on to Malak. Okay, so where's yours? Okay, so Malak is completed a Bachelor of Science in Kinesiology at McGill University. She's currently an MSc student at the Women and Children's Health in the Women and Children's Health program at University of British Columbia at the Uterine Health Lab. Malak is collaborating with clinical and community stakeholders to investigate the knowledge gaps regarding symptom and risk factor recognition for endometrial cancer and barriers to accessing care. Malak was awarded the BC Graduate Award for 2022 to 2023. So go ahead.
Hi, everyone. My name is Malak Ibrahim. I'm supervised by Dr. Aline Talhouk, and today I'll be presenting my thesis project, which is titled Spot the Difference, Recognizing Risks for Cancer and the Experiences of Normal Aging. So first, for some background on the topic, I know Sabine already went over, but endometrial cancer, or EC, occurs in the inner lining and muscular layers of the uterus, and it has become the most common gynecologic malignancy in the developed world. And unlike most cancers, the incidence of endometrial cancer is increasing. And when it's detected early, patients can expect an excellent 5-year survival rate of 96%. However, only 20% of patients will survive an advanced stage diagnosis. And that emphasizes the need for early detection and recognition of early signs and symptoms of endometrial cancer. Abnormal uterine bleeding, or AUB, is often the first noticeable symptom of endometrial cancer, and it's experienced by 90% of endometrial cancer patients. And abnormal uterine bleeding is defined as any bleeding post-menopause or any changes in regularity, frequency, volume, or duration of premenopausal menstruation in the absence of pregnancy. And unfortunately, most females cannot distinguish between what is considered normal and abnormal bleeding, or recognize that abnormal uterine bleeding could be a sign of endometrial cancer. There are also known racial and sociodemographic disparities that are associated with the incidence, care, and survival of endometrial cancer. So women of South Asian and Black ethnicity, as well as older women, make up a substantial portion of those who are diagnosed with endometrial cancer, yet they are underrepresented in research. And women with obesity are especially at risk for endometrial cancer, yet many avoid visits to healthcare providers, and even when they do go, they often don't get regular pelvic exams. And this is often due to avoidance of perceived healthcare provider bias or dismissal of symptoms as solely due to obesity. And currently, cultural, racial, and socioeconomic differences in endometrial cancer incidence, care, and survival have not been addressed. So the objectives of this study is to first capture and understand the experience of menopausal transition in a diverse group of females, especially those who are often underrepresented in research. We want to learn whether knowledge gaps are associated with certain sociodemographic characteristics. And lastly, we want to capture and understand what barriers females are facing when accessing care related to menopause and endometrial cancer. So for our methods, we're taking a 3-pronged approach, starting with a systematic review, where we will synthesize current literature on recognition of endometrial cancer risk factors and symptoms, mainly abnormal uterine bleeding. Next, we'll be doing qualitative interviews, which will be an in-depth investigation of the experiences of females in BC as they transition to menopause or face an endometrial cancer diagnosis to help determine gaps in education and resources. So for that, we'll be recruiting 20 to 30 participants of various ethnic and racial backgrounds, socioeconomic status, rural and urban settings, chronic conditions, as well as those who have already received an endometrial cancer diagnosis. And the interviews will help capture what participants think is normal or concerning during menopause, what they wish they knew during menopause, their experiences with the healthcare system and any barriers they might have experienced, as well as their familiarity with endometrial cancer risk factors and symptoms. And lastly, we'll be hosting a participant workshop where we'll further probe knowledge gaps and barriers to seeking help, as well as discuss digital health as a self-tracking tool for endometrial cancer symptoms and risk factors. And for the analysis, we'll be doing a qualitative thematic analysis, which involves examining the data, including the transcripts of the interviews, as well as the workshop, to identify common themes, topics, and ideas that come up. And we're allowing the themes to emerge from the raw data itself, and we will continue interviews until data saturation has been reached, meaning no new themes are emerging. And for future steps and implications of this study, we hope that this will help inform future educational efforts, raise awareness about endometrial cancer risk factors and symptoms in both healthcare providers and women in the community, as well as determine what barriers females face when accessing care for menopause or endometrial cancer to better tailor future interventions. These are my references, and thank you for listening, and thank you for my team. Thank you to my team, sorry.
Thanks, great work. Any questions?
I'm wondering when your project is going to be completed.
Yeah, so we are actually almost done the qualitative interviews, and we're hoping to host the workshop at the end of April. So getting near the end, we've got a lot of great information from the interviews, and we're hoping to learn a little bit more from the workshop as well.
I think you should write a blog for the Women's Health blog. I didn't know that there was a relationship between menopause and endometrial cancer. And if you're saying that so many women don't understand, the difference between regular or an abnormal bleeding, and that's even a symptom of endometrial cancer, yeah, you should think about writing a blog about your findings to help raise awareness about that.
Yeah, we're really hoping to get it out there, especially because what we're finding from the interviews is that a lot of people who might have had abnormal bleeding will often dismiss it as, oh, this is a change related to menopause. So a lot of awareness is needed about recognizing abnormal bleeding and when to go see your doctor about that.
Definitely. Well, you should reach out to the blog team.
I will, thanks. Okay, any other questions?
I'm wondering how specific of a symptom is abnormal bleeding after menopause? Or is it that it's not specific, but it doesn't matter because they should just go to their doctor and then they can get screened?
So it's not specific to endometrial cancer. It's indicative of a lot of other conditions. In post-menopausal bleeding, though, it's almost always something that you need to go see your doctor about. So it's not specific to endometrial cancer, but most of the time it is something that you do need to speak to your doctor about. So just raising awareness about that in general will help with a lot of other conditions as well as endometrial cancer.
Yeah, that's great. Any other questions? Or we do have a few minutes left. So if there are any other questions for any of the other speakers that we didn't get to or were percolating and you've thought of now, I'll leave a little bit of time for anyone to speak up. If not, that's okay. Thank you so much, everyone, for coming. We really appreciate everyone showing up to these. It's such a great knowledge translation event and such a great opportunity for the speakers and everyone who joins to learn a little bit about what's going on in women's health research. If you are on the call and you're interested in becoming a speaker, I think you can reach out to someone on the team. I'll just direct you to the website, the Women's Health Research at UBC, to figure out who the best person is to contact about that. And otherwise, we'll give you back 7 minutes into your day. And thanks so much again for everyone for joining.